Okay. Good afternoon or good evening. How are you all? Good to see you. My name is Kia James. I'm on faculty here at the University of San Francisco School of Nursing, and I will be your mistress of ceremonies this evening. And what I'd like to do is start out by introducing Dean Judy Karshmer, who's going to say a few words, and then I will introduce our speaker.
Thank you, Kia. So it's a pleasure to welcome you this evening to our annual Crawford Lecture. It's a special event for our practice partners, preceptors, alumni, current faculty, staff, and students. It is a small way for us to say thank you to your commitment to the school and our partnership in excellence for inpatient and family and community healthcare. So thank you and thank you. This year is a particular delight for me to welcome our speaker, who I met about a year and a half ago, but because I have the stage, I can't pass on the opportunity to talk about a few other things first. So I'm never one to pass up this opportunity. First, I want to tell you all about an exciting upcoming event, which is the USF Spring Gala, which is going to be sponsored by the Alumni Office and has named School of Nursing emeriti faculty who are USF alumna as recipients of the Professional Achievement Award. Now, so that's Betty Carmack, Fran Carter, Jane Corbett, Eleanor Hine, and Sister Brian Kelber. It's pretty cool. At this celebration, there will also be a special tribute to Father Lo Schiavo, Father Lo, who most of you know, and along with the other awards, so it's going to be a really fun event. The gala will be held on Saturday, April 9th at the Olympic Club on Skyline Boulevard. Starts at 6 with no host cocktails, not that you care, and dinner at 7, followed by the awards program. The cost per person is $90, and a table of 8 can be reserved. So it would be really fun, particularly those of you who have had one of these instructors while you're a student or as a faculty member to get together, have a table, and it would be great for as many of you as possible to attend. This is not only a terrific honor for our colleagues, but a really great honor for the School of Nursing, and it should be fun. If you have any questions or want to have information about the event, there are some invitations on the table. Invitations, that's code for this is how you pay. The invitations are on the table as you go out, or you can also contact the alumni office. On another subject, while I have my place on the BIMA here, all of you know that Nurses Week is coming up, as well as Mother's Day. And you may or may not be fully aware that Mother's Day and Nurses Week always coincide. So at USF, we have a special opportunity to honor mothers who are nurses by giving a donation to the School of Nursing, and a special card is then sent to your mom in honor of your recognition of her. It's a lovely way to say thank you, and it's a wonderful way to honor that special person, as well as help educate the next generation of nurses. I've distributed postcards to that effect as well this evening. In addition, on May 16th, this is not about money, this is about thank you. We're going to have a student showcase for folks who have been donors to the School of Nursing. And it's going to be an opportunity May 16th here in from 4 to 6. Students will be showcasing some posters that they've been doing about change projects in the community, in their clinical agencies. A few of the students will talk about immersion trips to Guatemala and Belize, and you'll have an opportunity to interact with them. So we urge you to mark your calendars to join us on May 16th. Now, I'd like to also acknowledge some very special folks. Sister Geraldine McDonald, who is the previous dean of USF. As many of you know, Sister Geraldine was dean and has left a wonderful legacy, for which I thank you particularly. Thank you. And members of our advisory board who are here tonight: Sharon Wicker, Lisa Sabatini, Maureen O'Hara. If you'd all stand. Sister Aline Egan. Now, stay standing. No, stay standing. This is fine. And our Associate Dean, Pat Lynch. Did I miss anybody? No, stay standing. And now members of our Dean's Circle, Raki Newman and Patty Ross. Please stand. Did I miss anybody? See, if you stay standing, you'll get it at the end. Some folks from our advancement office, Gertie, Arnold, and Nikki, I guess is not here. And now I want to acknowledge our faculty, full and part-time. Please stand. Previous and current. Our staff, please stand. You guys are not following directions well at all. Our preceptors, please stand. And now friends of nursing, please stand. Okay. The point was, had you followed directions by now, everybody would be standing. In any case, thanks. It is your contributions that make the school what it is today. So thank you, thank you. Now, I have to just say that this event doesn't happen without a lot of work on some very special people, and I want to thank them for their dedication to this special event. Crawford Lecture is a result of a collaboration between the School of Nursing Faculty Development Committee and our USF Alumni Office. Specifically, I'd like to acknowledge Kia James, Chair of the Faculty Development Committee, and its members, Pam Bonnell, Maggie Hansen, Joe Loomis, and although she's not a member, Mary Lou DiNatale, who actually sort of acts like a member. Yay. And our alumni office, Annette Anton and her crew. I think she's just stepped out. Christina Ty in our office has been the point person for the event, and there's a crew of students who are personing the sign-in table. Thank you to them. So I know how hard you all work. I appreciate it. And it is also my great thank you to the Beta Gamma chapter of Sigma Theta Tau International, the Honor Society for Nursing, for the generous support for tonight's event. So that's it. I'm sure you're much more excited to hear from our speaker this evening. So without further commercials, I will turn this over to Kia James for introducing our speaker. Thank you.
Thank you, Dean Karshworth. Well, we have to have at least one more commercial. And that is, in light of our speaker this evening, who is representative of Health and Human Services and also Public Health, just wanted to let you know that we are starting a Masters of Public Health program in the fall. So if you want some more information, it's out on the table. Feel free to pick it up, as well as other things that are out there too. So, like how to give money. Well, it is my distinct pleasure this evening to introduce to you Rear Admiral Kerry Paige Nesseler. And the first and foremost thing that I want you to know about her is that she is a USF alumnus, 1978. Yay! I can relate. This is the first time you've been back to San Francisco for 30 years. And we are so happy to have you here this evening. A little bit about her, besides getting her bachelor's degree from USF in 1978, she also has an MSN from the University of Hawaii. But most impressive is her titles. And I look at these titles, and I didn't see all of these titles on the materials I had, so I'm going to let you read those, but I'm going to tell you the ones that I know of. First of all, she is the Director of Office of International Affairs or Global Affairs. Okay. The Director also of the Office for Commission Corps Affairs for Health and Human Resources Administration within the U.S. Department of Health and Human Services. This is a very high-ranking, if not the highest-ranking officer in the Public Health Service. Am I correct? Yes, she is. So a little bit about Rear Admiral Nesseler. She's had a long leadership career in public health and federal government. She started her federal career in 1990 working as a nurse consultant for the Bureau of Primary Care. She's also held various leadership and administrative positions within other federal agencies, including the Center for Disease Control, and held positions in epidemiology and maternal child health care. In 2006, Kerry Paige Nesseler was appointed to Director for the Office of Global Health Affairs, and also the Office of Commission Corps Affairs in the U.S. Department of Health and Human Services. What she does is she develops strategies to maximize HRSA, which is an acronym for Health Resources and Services Administration, to maximize HRSA's participation in efforts to improve the health care for vulnerable populations worldwide. She also coordinates and advances international health policy and resource development within HRSA. She also is in charge, which is really impressive, directs and implements the Health and Human Services vision for the U.S. Public Health Service, but leads almost 500 commissioned health corps officers in that effort. So, would you please put your hands together and give Rear Admiral Paige, Kerry Paige Nesseler a warm welcome. Thank you. Thank you.
Thank you so much, Dr. James. I really appreciate that warm introduction. And thanks so much to Dean Kashmir for inviting me here today. And what an honor it is to have you here, Dr. Geraldine. I didn't know you were going to be here, and I am so honored to see you here in the audience. And thank you so much for all that you did for me and all the education and the time that you gave to the nursing profession. You truly are a hero in our eyes. Thank you, ma'am. But it truly is an honor to be here as the chief nurse of the United States Public Health Service here at my own alma mater. It's taken me back a bit. As she said, I haven't been on campus, I'm embarrassed to say, in 33 years. And you know, some of it actually looks the same. Mary Lou, where's Mary Lou? Mary Lou she picked me up from the hotel today and drove me around a bit and was gracious to show. Actually, we drove by like 4 of the places I used to live, which was kind of fun and all. So thanks so much, Mary Lou, for your time this afternoon, too. But you all had me thinking and reminiscing just a bit, and I just have a couple of little things to share with you. Some of them are more fun, and some is actually about nursing. But because we're right in the middle, I don't know if anybody of you are NCAA fans, but I guess we're in the middle of the Final Four, yeah? Well, in 1978, Bill Cartwright played for USF, right? And the Dons. In the late 70s, 1978, the year I graduated, the Dons won their 12th West Coast Conference Championship. And Bill went on to win 3 NBA titles, 1991, 92, 93, with our ever-famous Michael Jordan and the coach Phil Jackson. So, you know, I do recall USF was the Dons were quite the basketball team. In 75, you know how much it cost to cross the Bay Bridge? I came over because I'm from Oakland, so my family and I came over and I said, $5 for off hours and $6 for regular day? And so it's 50 cents to cross the bridge both ways. 75, you know, it was really just the ending of the Vietnam War. I lived in Haight-Ashbury. And, you know, I really did see that final phases of the hippie era and the beginnings of the transformation of the real estate values in San Francisco, right? It's amazing. 78, no HIV/AIDS. Nursing. First class, I think, and Dr. Geraldine, you might correct me, but I think we might have been the first class where we had the choice if we wanted to have a nursing cap or not. And I wish I'd got one and I didn't. I would love to have had it there. Does anybody have their hats? Their caps, yes. But 79, which was my first full-time position, I was over at Alta Bates Hospital, and we really were transforming maternal-child health at Alta Bates. We really, I think, were some of the first in the United States to institute alternative birth centering, which is probably such commonplace to the students here today. But we did alternative birth centers, rooming in, father's participation in the delivery, early postpartum discharge. Oh, we were such rebels then, weren't we? But, you know, and also we were sort of in the beginning of the movement of nursing and primary care and sort of nursing taking the lead in owning all of the patient and the care that we provided there. But, you know, I'm not going to even talk about computers or cell phones or Blackberries or the internet or Facebook. You know, that did not exist. We were writing our papers by hand or at the typewriter and maybe using carbon copies. So anyway, we did have some good times here, though. It was a great place to graduate, a great place to learn about nursing, and I take that education with me for everything that I have done, and I really appreciate all that the faculty, I believe there are some faculty here that were my teachers, and thank you all for everything that you have done. So I think I'm going to see if I can get this. It's the red one. Okay, great. Today I want to go over a bit about what is the United States Public Health Service Commission Corps, what is this uniform that I am wearing. People really don't know who we are. To this day, my father says, I don't know, she works for the Navy or something. No, we're in the Commission Corps. The United States Public Health Service Surgeon General, who is America's doctor, is above us. I'll talk a little bit about her and her priorities. What is the Chief Nurse Officer position in the Public Health Service, and what are some nursing opportunities in the United States Public Health Service? A little bit about the Affordable Care Act, which is, you might know it as healthcare reform, the Affordable Care Act, and what it's doing for nursing. And then just a smidgen on HRSA's Title VIII program, which is Nursing Workforce Development Program. I know the deans and the faculty really know Title VIII, but I think the students ought to hear. It's just good for you to know where our money comes from Congress that we implement in the Public Health Service and in the administration of HRSA to really help educate and train our nurses. So the United States Public Health Service, is this working? Okay, yeah. For nurses who are interested in serving the nation while at the same time helping meet the healthcare needs of Americans, especially in remote and underserved areas, there's a special cadre of uniformed health professionals within the United States whose mission is to do just that, the United States Public Health Service. Our mission is to protect, promote, and advance the health and safety of our nation. As America's uniformed service of public health professionals, the Commission Corps achieves its mission through rapid and effective response to public health needs, leadership and excellence in public health practice, and advancement of public health science. Our core values are leadership, service, integrity, and excellence. Leadership, that we provide the vision and the purpose in public health through inspiration, dedication, and loyalty. Service, that we demonstrate a commitment to public health through compassionate actions, stewardship of time, resources, and talents. Integrity, that we exemplify uncompromising ethical conduct and maintain the highest standards of responsibility and accountability. And excellence, that we exhibit superior performance and we continue in improvement in knowledge and expertise. Now, doesn't that sound like the profession of nursing? There are, if you don't know, 7 uniformed services in the United States. Many of you have heard of. There's the Army, the Navy, the Air Force, the Coast Guard, the Department of Oceanic Atmosphere, the United States Public Health Service, and the Marines. Now, you've got the Army, Navy, Air Force, and Marines are under Department of Defense. Carry guns. They're out there helping defend and protect our country. You have the Coast Guard. It's under the Department of Commerce. And then you have the Department of the National Oceanic and Atmosphere, NOAA, that's also under the Department of Commerce. Then you have the United States Public Health Service. We are under the Department of Health. We are not under the Department of Defense. So we don't carry guns. We're all healthcare providers. We're all officers. We do not have an enlisted corps. So the major difference between the 5 military branches in the Public Health Service and NOAA is that the PHS and NOAA are not armed forces, but share in protecting the U.S. through their different and unique missions. Now, for some of you that are history buffs, well, this will be kind of fun. Others, maybe, it's like, oh, please. Okay. A little history, though. In 1798, over 200 years ago, John Adams, the second president of the United States, signed into law the Act for the Relief of Sick and Disabled Seamen. A year later, Congress extended the act to cover every officer and sailor in the U.S. Navy. The act led to the gradual creation of a loose network of locally controlled marine hospitals along the coastal and the inland waterways. 72 years later, in 1870, hospital administration was centralized in the Marine Hospital Service, with its headquarters in Washington, D.C., under the position of a supervising surgeon or the first Surgeon General. The prevalence of major epidemic diseases such as smallpox, yellow fever, and cholera in 1878 spurred Congress to enact the National Quarantine Act to prevent the introduction of contagious and infectious diseases into the United States. Congress later extended the act to prevent the spread of disease among all the states. The task of controlling epidemic diseases through quarantine and disinfection measures, as well as immunization programs, fell to the Marine Hospital Service. Finally, the birth of the Commissioned Corps occurred in 1889, when legislation formalized the Corps as the uniformed service component of the Marine Hospital Service. Congress organized Corps officers along military lines with titles and pay corresponding to Army and Navy grades. So we do wear a Navy uniform. We do have Navy rank. We just have a little bit of a different emblem on our uniform. And this is a symbol of an 07 or a rear admiral. I think we're good. The history of the United States Public Health Service Commission Corps is the history of health defense in the United States. For 213 years, the United States Public Health Service Commission Corps has been our nation's front line against the spread of disease, from sailors returning from foreign ports, to immigrants entering the country, to communities affected by natural and man-made disasters, to public health efforts for all Americans. Today, the Corps serves the better public health on multiple fronts. Corps officers are involved in disease control and prevention, biomedical research, regulation of food and drugs, mental health and drug abuse, healthcare delivery, and international health. As a vital part of the U.S. Public Health Service, the Commission Corps is an essential component of the largest public health program in the world. Currently, there are over 6,600 active duty officers who are serving over 800 duty stations throughout the world, fulfilling its mission to protect, promote, and advance the health and safety of our nation. There are 11 professional categories: medical, dental, nurse, engineer, scientist, environmental health, veterinarian, pharmacists, dietetics, therapists, and health service officers. Each of these 11 professional categories has a chief. So I am the chief of the nursing category under the Surgeon General. So you can see we really do work very interdisciplinary. You'll get on a deployment team, or you'll work at CDC, or you'll work within HRSA even, and you'll work with many of these different disciplines as an interdisciplinary team. This is our Surgeon General currently, Regina M. Benjamin, Dr. Benjamin. She's the 18th Surgeon General of the United States. As America's doctor, she provides the public with the best scientific information available on how to improve the health and the health of the nation. Dr. Benjamin also oversees the operational command of the 6,600 uniformed health officers. Founder and former CEO of the Bayou Laboratory Health Clinic in Alabama, the former Associate Dean for Rural Health at the University of South Alabama College of Medicine in Mobile, immediate past chair of the Federation of State Medical Boards of the United States. In 1995, she was the first physician under the age of 40 and the first African-American woman to be elected to the American Medical Association's Board of Trustees. And here's a snapshot of some of her priorities for the nation. Wellness, prevention, and promotion is one of the main Surgeon General's health priorities, as it supports the First Lady, Michelle Obama's Let's Move campaign to raise a healthier generation of children. This is the first time, and I know many of you know this, but it still astonishes me, but it's true. This is the first time in the history of our country that our children face the possibility of a shorter lifespan than their parents. According to the statistics from 07 to 08, CDC found that 34% of adults aged 20 years and over are obese. In addition, 34% of adults aged 20 years and over are overweight. These are alarming rates, as over 60% of adults in America are overweight or obese. And what is even more alarming is the obesity rate for children and adolescents under 20. Between 2007 and 2008, statistics from CDC show that 48% of children and adolescents under the age of 20 are obese. Obesity not only affects the health of individuals, families, and healthcare costs, but also our national security. Obesity affects national security because obese adults who wish to join the military are not eligible due to failure to conform to weight and physical fitness regulations. In addition, obesity is also one of the top reasons why young men and women fail to be retained on active duty in our uniformed services. The Surgeon General's vision for a healthy and fit nation publication is included in the Wellness Prevention and Promotion Program, which addresses individual healthy choices and healthy home environments, creating healthy child care settings, healthy schools, healthy work sites, and mobilizing the medical community. Another one of her priorities is reducing HIV/AIDS. There are estimated to be about 850,000 to 950,000 U.S. residents who are currently living with HIV infection, including 25% who are unaware that they are infected. 40,000 new HIV infections occur in the U.S., while about 5 million new cases occur worldwide. According to the National Center for Health Statistics, HIV infection is the leading cause of death for African American men between 35 and 44 years of age, and the fifth leading cause of death for people between the ages of 25 and 44 in the U.S. And until an effective vaccine is developed, communities can help reduce the high HIV infection rate by supporting programs that emphasize behavioral risk reduction and other prevention strategies. In addition, communities must aid at-risk individuals in accessing programs that will enable them to be diagnosed early for HIV and for them to receive the proper care and treatment. Tobacco prevention, we all know this one. Tobacco use, including cigarette smoking, cigar smoking, and smokeless tobacco, remains the leading preventable cause of death in the United States. How long are we going to have to say those statistics? Annually, cigarette smoking accounts for 1 of every 5 deaths in the U.S., or about 443,000 people. The Surgeon General released a report in December of 2010 on how tobacco smoke causes disease, the biology and behavioral basis for smoking attributable diseases. And reducing rates of tobacco require a solid partnership between federal government, states, a comprehensive state and local level tobacco control program. And congratulations to California, an example of a comprehensive state level tobacco control program that creates environments which discourages or bans smoking in the state of California. You have some of the most restrictive smoking laws in the nation, where smoking in government workplaces, child care facilities, schools are prohibited, and smoking on private workplaces, restaurants, bars, recreational, cultural facilities are restricted. One of her priorities, eliminating health disparities. I'm sure many of you heard of Healthy People. Healthy People is a national agenda that communicates a vision for improving health and achieving health equity. Concerning health disparities, the goal for Healthy People 2010 was to eliminate, not just to reduce, health disparities. In Healthy People 2020, that goal was expanded to achieve health equity, eliminate disparities, and improve the health of all groups. Healthy People 2020 defines health disparity as a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage. So throughout the next decade, Healthy People 2020 will assess health disparities data in the U.S. population by tracking rates of illness, death, chronic conditions, behaviors, and other types of outcomes in relation to demographic factors, including race and ethnicity, gender, sexual identity and orientation, disability status or special health care needs, geographic location, rural and urban, And so, as you can see, the department is working to eliminate, not just to reduce, health disparities. A couple others: reducing medical errors. The Institute of Medicine, IOM, reported that 44,000 to 200,000 people die annually due to medical errors. And these errors are caused due to complex health systems and poor communication between healthcare providers and their patients. In order to reduce medical errors, providers should ensure that their patients are fully involved and informed of the preferred choice of treatment. And last, but of course not one of her only, but last on my list is violence prevention. It's a serious problem that can have lasting and harmful effects such as depression, post-traumatic stress disorder, panic attacks on their families, friends, and the community. And for your information and your use, there's a Striving to Reduce Youth Violence Everywhere, or STRIVE, S-T-R-Y-V-E, pronounced STRIVE. It's a CDC and partners guide for communities, states, and the country to use to help prevent youth violence. But in addition to youth violence, gender-based and workforce violence are also important issues that affect nursing. Specifically, nurses suffer the largest number and the highest rate of non-fatal workplace violence of all the health professions. And last, integrating primary health care services and oral health and mental and behavioral health. We don't need to, like cut off the head and not think about our oral health and our mental health. And, we need to integrate all of that into primary health care. The Surgeon General had a report on oral health in 2000, recognizing this need, along with the profound oral health disparities in vulnerable populations, including children, the elderly, individuals with complex health conditions, and those living in rural, low-income, and minority populations. So just in recap, there's 4 listed reports here that I think that are recent. Again, the Surgeon General Vision for a Healthy and Fit Nation, Healthy People 2020, a report of the Surgeon General on how tobacco smoke causes disease, and which I didn't talk a lot, but you surely can pull it up. It just was released last January. The Surgeon General's call to action to support breastfeeding. Very important for us in our nursing. So just back to history a little bit, but about nursing. The Public Health Service Act passed by Congress on July 1st, 1944. Took us that long, huh? Authorized the appointment of qualified professional nurses as U.S. Public Health Service Commissioned Corps officers. In July of 1945, the first nurses received their commission. Thus, the discipline of nursing was recognized nationally by the Public Health Service as a profession. The process of the nursing field becoming a profession occurred slowly over time. And there was a real relationship to those Public Health Service nurses and the Marine hospital system and all of the diseases, and how they really began to feel that they needed those nurses to help move the system along. But the nursing category, of all those 11 that I showed you, of course, we're now the largest category in the PHS. We have more than 1,550 Commissioned Corps nurses, and over 3,000 civil service nurses are employed in the federal government. The Chief Nurse Officer roles and responsibilities really are to be the liaison between the nurse category, the Surgeon General, and to support the Surgeon General and the President's priorities. The first chief nurse in 1945 was Rear Admiral Lucille Petrie, and I am now the 9th. So we've had 9 chief nurses since 1945. Dr. Faye Abdella, who I'm sure many of you must know, Dr. Faye Abdella, who actually is doing very well. She's still in Washington, D.C. She was chief nurse for probably about almost 17 years. And after that, they gave us a 4-year term. So now we all have 4-year terms. So I'm chief nurse from November 109 through October 31st of 2013. And then they will choose another one from our ranks. So students, if you aspire to be chief nurse, join the Commissioned Corps. The Chief Nurse Officer provides consultation advice to the Surgeon General on issues on policy, particularly in areas related to the nursing category. The CNO also serves as a focal point for issues of interest and concerns to the nursing category, seeking to resolve these issues through available and appropriate means. In order to perform professional and strategic alliance, to improve the overall practice of public health, and to coordinate common cross-cutting issues of national significance, the CNO interacts with their counterparts with the other uniformed services and the VA. Every other month, the chief nurse of the Army, the Navy, the Air Force, and the reserve units, we all have a meeting, and the VA and the Red Cross. All those chief nurses come together every other month, and we talk about issues on the horizon and new policies that might be coming out and what we can all do to work together. My chief nurse priorities. I'm rekindling our nursing strategic plan to develop the goals and objectives that are in line with our new Surgeon General, Vice Admiral Regina Benjamin. As you may know, she has pledged an emphasis on wellness and prevention. The true nursing model, and one area where nursing has much expertise. Focus on health workforce issues, trying to address our national nursing shortage. To increase the number of nurses and the number of nurses working in underserved areas. Most of the congressional training and education dollars for nursing resides within the HRSA's Division of Nursing. And I need to say, though, I'm very proud to tell you HRSA is headed up by a nurse for the first time ever. Dr. Mary Wakefield heads up HRSA, and the Division of Nursing is under her. She is my boss. The Surgeon General is my boss on one side, and Dr. Mary Wakefield is my other boss. So when you're chief nurse, they say, okay, you want to be chief nurse, but you got to still do your other job. So, we got two jobs. So about 50% of my time is chief nurse, and about 50% of my time works for Dr. Mary Wakefield as Director of Office of Global Health. The agencies are who pay our salaries. So when you're in the Commission Corps, you're under the Surgeon General, but you're actually working for the agency. So you're working at CDC. You're working for IHS. You're working for FDA. And I'll talk about where the opportunities are for nursing. But my focus area of health workforce and trying to get more nurses out to underserved areas, of the 1,550 nurses in the Corps, a little over 1,000 are stationed either in Indian Health Service, BOP, or Division of Department of Immigration Health Services, providing direct health care services for folks that really need it the most. Another priority is to give voice to science and to evidence-based practice. The federal government has the expertise at NIH, specifically the National Institute of Nursing Research, the NIH Clinical Center, FDA, CDC, and the Agency for Healthcare Research and Quality. Promote the intelligence of prevention. As you know, there's much interest in prevention of obesity, especially with children, mental health, and our experts at SAMHSA. Nurses know prevention saves. Strengthen our skills of protection. I'll talk a little bit about how the Commission Corps does go on humanitarian, diplomatic, health diplomacy missions. We do need to maintain basic readiness. Nursing, out of the 11 categories, has reached the top 5 categories of the 11, and my goal is for us to reach 100% and be number 1. We're not there yet. And last is to support health diplomacy in our working relationships with other countries and the nurses. As Chief Nurse of the Public Health Service, I sit on the WHO Government Chief Nurse and Midwifery Officers, and usually we meet in Geneva every other year. Last year, I think they met in 2010, so we'll meet again in 2012. And in May of 2010, there were 75 countries that brought their chief nurses into Geneva. When I talked about rekindling the Federal Public Health Nurse Leadership Meeting, these are many of your chief nurses that work within those agencies. So I brought them together to hope to coordinate and collaborate so all the agencies at least know what each of us are doing, and we're sort of not duplicating efforts, and we're working more as a whole. You'll see Dr. Mary Wakefield there. She's in the white with the black Dr. Pat Brady sitting next to her. She runs the National Institute of Nursing Research. That's myself, another Admiral. You might all know Dr. Sue Hassmiller with the Future of Nursing Report from RWJ. She came and addressed us on the RWJ Future of Nursing Report. And that's Dr. Deborah Parham, who runs our HIV/AIDS Bureau, Rear Admiral Deborah Parham. She is the highest-ranking nurse in the Commission Corps. She is a 2-star in 08, and she also works for Dr. Wakefield. Qualifications. If you want to be a nurse officer, you have to be a U.S. citizen. Are we there? You have to be less than 44 years of age, be medically qualified, bachelor's degree or a master's degree with no qualifying bachelor's degree from a nursing program that is accredited by the National League for Nursing Accrediting Commission or the Commission on the Collegiate Nursing Education. You have to have a current, unrestricted, and valid nursing license from one of the 50 states, D.C., Puerto Rico, or the U.S. Virgin Islands or Guam. You have to pass the NCLEX. And I've heard many of you have taken it and passed. Congratulations to all of you. So if you're interested and you meet some of these qualifications, please look us up. We are interested in recruiting more nurses. What's, to me, one of the best things about this is you have so many different opportunities. I started in 1986 after working in Alta Bates, then I moved to Hawaii, as you heard, got my master's. I've enjoyed, in 1986, my first assignment was in Minnesota, near Duluth, Cloquet, at Fond du Lac Indian Reservation, and I worked as a nurse midwife. So I really had, they handed me a grant, which lo and behold, I ended up finding out came from HRSA. HRSA was right. They handed me a grant and said, we just got this money, start a new prenatal clinic for our Indian reservation. So very exciting. I was there for 4 years. Then went down to Atlanta and worked in the regional office there, then worked at CDC for a bit, came up to Washington, D.C., worked for the Maternal Child Health Bureau. I ran the Bureau of Health Professions that has the Division of Nursing under it, and then was moved to Office of Global Health Affairs. People have many different experiences. What's nice, though, is you can move around. You can do all these things, but you're sort of in the same system. So when you do 20 years, you've got some retirement. You're 30, you can do up to 30. Everything from direct health clinic care, and I'll talk about in a minute. This is the org chart of the Department of Health and Human Services. Again, we're not Department of Defense. Those middle ones there are all your agencies under the Department of Health. The offices support those, but you've heard of ACF and AOA and CMS and AHRQ and FDA. I'm sure you've all heard of many of those. Those are places that you can work. But in addition to that, we also have agreements with other agencies not within the Department of Health. We have nurses working in, we have nurses working in the Department of Homeland Security. They're still Commission Corps, they're still within our system, but they've been detailed there. We have nurses working in the division of, which is the Immigration Health Services that I mentioned. NOAA Corps, we have some Commission Corps PHS officers in NOAA. We actually have some of them working for the Department of Defense and the Armed Forces working with post-traumatic stress disorder. If they don't convert, they're not an Army nurse, they're still a PHS nurse. Department of Interior at the National Parks. There was actually an announcement I just put out last month that if you want to work at Yosemite, you can go be a clinical nurse at Yosemite. They were recruiting 3 nurses. Department of Justice, Federal Bureau of Prisons, U.S. Marshal Service, Department of State, Foreign Services and USAID, EPA, USDA, and local and state health departments occasionally. Those are a little harder to get. So what do we do? As a nurse officer in the Commission Corps, you'll go places in your profession, in the community, and the world. You're valued for your initiative, your resourcefulness, and your professional judgment. You'll gain clinical and leadership experience while treating diverse and challenging cases. You can live and work in remote communities. You can provide care to those that are the most in need. Nurse officers in the Corps perform traditional clinical services including inpatient and outpatient care ranging from newborn care to geriatrics, from obstetrics to orthopedics, to mental health, from prevention to chronic or acute disease. You can conduct research. You can maintain and manage and review approval of drugs and medical products. You can respond to public health emergencies, develop and implement national health policies, develop and implement clinical practice guidelines and evidence-based reports on health care, coordinate prevention and education efforts on a variety of public health issues, develop nursing training and education programs for basic and advanced practice nurses. The focus is on improving systems of care for an entire community of peoples. While there is plenty of opportunity for direct patient care, there are opportunities to work on organized national disease prevention and health promotion, which can make an impact on the disease rates, the health disparities, and access to care. A few examples of some missions that we've been on. The Commission Corps partners with the Navy and other sister services in medical training and missions to developing nations in responding to foreign disasters. The photo on your left-hand side shows the United States Navy ship Comfort. The Comfort departed its home port of Baltimore, Maryland on March 17, 2011 in support of a humanitarian civic assistance mission called the Continuing Promise of 2011. And during their 5-month Continuing Promise 11 mission, they will go to 9 different countries in Central and South America and the Caribbean. Selected ports in Colombia, Costa Rica, Ecuador, El Salvador, Guatemala, Haiti, Jamaica, Nicaragua, Peru, and we'll visit many of those different countries. The photo on the right-hand side shows the United States Navy ship Mercy. The Mercy provides mobile surgical hospital service for use by appropriate U.S. government agencies in disaster or humanitarian relief, or limited humanitarian care to these missions in peacetime operations. There's the Pacific Partnership 2010. That ship sailed from its home port in San Diego, here in California, on May 1st of 2010. The Pacific Partnership 2010 is the 5th in a series of U.S. Pacific Fleet humanitarian civic assistance endeavors aimed at strengthening our regional relationships with host and partner nations in Southeast Asia and Oceania. The Pacific Partnership 2010 visited 6 nations during their 5-month deployment, in which nearly 110,000 patients were treated. They visited Vietnam, Cambodia, Indonesia, and a few other southeast countries. Usually when a Commissioned Corps officer joins the Navy and helps with these missions, generally your deployment is 2 weeks. When you're going to a national disaster on these ships, it would be for 1 month. And most of that is voluntary. The USPHS was a partner on all of these humanitarian missions. But we have some of our international emergencies have been deployed to include Haiti, the earthquake in Haiti in 2010, and the tsunami in Indonesia that occurred in 2004. We are on standby currently for the most recent crisis in Japan. And in addition to international emergencies, we're also deployed stateside. For example, we were in response to emergencies that included Hurricanes Katrina and Wilma in 2005. So humanitarian missions can be a part. Usually you are on call 1 month. Every 5 months you're on call for a month. If you get called up, if the president declares it a national emergency, you will go out for 2 weeks. And if it's not considered a national emergency, you have some flexibility in saying, no, at this time I don't choose to go out. Most of you are excited. You're kind of hoping you get to go out. So you're only on call every 5 months. You're kind of hoping you get to go out for 2 months, 2 weeks. And now changing gears just a little bit. I think all of you know, very exciting for us, on March 23rd, just had an anniversary last week, 2010, a new day for healthcare. After a year of striving, after a year of debate, after a historic vote, healthcare reform is no longer an unmet promise. It is now the law of the land. A year ago, President Obama passed health care reform, now known as the Affordable Care Act. The passing of the Affordable Care Act brought many benefits, and with it, we have made great strides. Families all over the nation now have more freedom and control over their health care choices. Senior citizens on Medicare will have their preventive services covered without copayments. Under the Affordable Care Act, preventive services will expand for all Americans without copayments. The Affordable Care Act also ends discrimination by insurance companies against children who have pre-existing conditions. Starting in 2014, discrimination for pre-existing conditions will be gone for all of Americans. In short, the Affordable Care Act makes it possible for millions of people who may not have had health care in years to now have routine access to a primary preventive care for screening, intervention, and prescription medications. Some initiatives of the Affordable Care Act impacting on our profession of nursing. There's the National Prevention, Health Promotion, and Public Health Council. This is formulated by the President and chaired by Vice Admiral Dr. Regina Benjamin. The nursing present is expected to be strong on this council. The mandate is to coordinate at a federal level all of the activities with respect to prevention, wellness, and health promotion across the federal government and the United States. And their other mandate is to develop a national plan with regard to these issues and provide recommendations to the President and to the Congress concerning pressing issues related to health promotion and wellness. CMS, or Centers for Medicare and Medicaid Services, has hundreds of provisions in the Affordable Care Act they are responsible for implementing. One is providing insurance to the uninsured. CMS is incorporating the goals of the Institute of Medicine, which are safe, effective, person-centered, timely, efficient, and equitable care. The focus is on patient-centered care, better health, and looking at the impact on the community versus the past medical model nationally. The Center for Medicare and Medicaid Innovation, established by the law, will establish a nurse steering committee in which nurses will have a voice. The purpose of the steering committee is to give nursing input on policy decisions, delivery of care across the whole agency. Our National Institute of Health, our National Institute of Nursing Research, a concerted effort is being made to translate research into practice. To reform our healthcare system, we need to find out what works best and what does not work. The Affordable Care Act formulated a new institute called the Patient-Centered Outcomes Research Institute, and its duties involve identifying comparative effectiveness research priorities. NIH is creating interdisciplinary teams to translate the complicated research speak into a language that all health professionals use and apply in the most recent and current evidence-based practice into their daily practice. And in HRSA, under our leadership of Dr. Mary Wakefield, there are 3 strategy priorities underscored in the Affordable Care Act: primary care, increasing our community health centers throughout the nation, a need to focus on home visiting programs, nurse-managed care centers, coordination of care, community-based aspects, school-based programs, emergency services, and geriatric care. Workforce analysis, areas related to work and health promotion, disease prevention, and wellness, really looking at what is the need, the supply and demand with nursing, and primary care in general, primary care physicians too. Healthcare quality, studies related to care and care delivery models, very high on the agenda. Combining oral health and primary care, interprofessional care and oral health, pediatric nurse practitioners, care for children, and are really more frequent visitors of children than the dentist. So really looking to nurses to look within those children's mouths, to collaborate with the dentists, and reduce oral health disparities, especially in children, and eliminate the health care focus that does not include oral health and behavioral mental health. In HRSA, there is Many of you know about nurse-managed healthcare clinics. Many of you don't. But Section 5028 of the Affordable Care Act created Section 33A1 of the Public Health Service Act, which authorized a new program to provide grants to develop and operate nurse-managed healthcare clinics. They have been in existence more. This is just helping give it more of a boost. A nurse-managed health clinic is a nurse practice arrangement managed by advanced practice nurses that provide primary or wellness services to underserved or vulnerable populations, and that is associated with a school, a college, a university, or a department of nursing, or a federally qualified health center, or an independent nonprofit health or social service agency. Does USF have any affiliation with the Nurse Managed Care Centers, Regina? Oh, good. Congratulations. The new grant program has also been established to fund community-based nurse-managed health centers that are operated and managed by qualified advanced practice nurses. The Affordable Care Act recognizes the contributions and the importance of nurse-managed care, setting up a grant structure by which an additional $31 million is allocated to boost the number of nurse practitioners and nurse midwives by 600 clinicians, and $15 million provided to support 10 new nurse-managed health centers. Already the fastest growing segment of the primary health workforce, nurse practitioners and advanced practice nurses provide more than 40% of the care at health centers. In the last fiscal year, HRSA funded 21 nurse-managed health centers across 13 states for a total of $7 million to support health care for underserved populations. And also, HRSA has the National Health Service Corps. This is not necessarily specifically a nursing program, but it's a loan and scholarship program for primary care docs, nurse practitioners, midwives, dental hygienists, dentists, mental health and behavioral health to go work out in an underserved area. You go out and work in an underserved area, you are there, they are your employer, you are their employee, we don't own you, but you work for them, they pay your salary, but we give you money to serve in that underserved area to help you repay your loans and scholarships. Great benefit for nurse practitioners and nurse midwives if you're really looking for loans and scholarships. If you don't want to join the Corps, this is another way to help get your loans and scholarship paid. I believe, and I'm not sure, and I know I'm being taped, but I think it's for every 2 years you serve, for every year that we provide you loan and scholarship, you owe us 2 years. The National Health Service Corps federal program provides loan repayment assistance to up to $60,000 for eligible health care providers in exchange for their promise to protect and provide service in communities that are experiencing critical shortages of health care providers. And the expansion of the National Health Service Corps means that hundreds of more rural, underserved communities will have a doctor, a nurse practitioner, a dentist serving their primary health care needs. So a little bit on Title VIII. I think the faculty are very familiar with Title VIII. This is where Congress provides to HRSA money to support nursing education and training and practice. It was called the Nurse Education and Practice Improvement Act of 1998, also known as the Nurse Education Act, which provides federal support for nursing education program at various points on the continuum from entry-level preparation through graduate study. The NEA helps address the nursing shortage by enhancing opportunity for students to become nurses. The NEA supports 3 major grant programs: advanced nursing education, nursing workforce diversity, and basic nursing education and practice, 2 loan repayment programs, the Nurse Education Loan Repayment Program and the Nurse Student Loan Repayment Program. In 2002, the Nurse Reinvestment Act amended the Public Health Service Act, which directed the Secretary to provide nursing loans and scholarships in exchange for at least 2 years of nursing service at facilities with a critical shortage. The Act permits part-time service now if the aggregate service equals full 2-year terms. And this is a wheel that we use to show the different programs under Title VIII. This workforce development program administered by HRSA are the primary source of federal funding for nursing education. Title VIII was expanded and improved by the Nurse Reinvestment Act, and the major grant programs are there. In fiscal year 2009, nursing workforce development programs assisted at least 65,000 students in obtaining their nursing education through either individual student support and programmatic support. Title VIII, again, the largest source of federal funding, assisted at least 70,811 students in obtaining nursing education in 2009. Up at the top, Advanced Nursing Education, Section 811, funds advanced nursing education programs to provide traineeships that help pay tuition, books, fees, and a living stipend for registered nurses enrolled in programs that prepare nurse practitioners, clinical nurse specialists, nurse midwives, nurse anesthetists, nurse administrators, nurse educators, public health nurses, and nurses in other specialties requiring advanced education. And congratulations to the University of San Francisco. I hear you're the first university to have a Doctor of Nursing Practice program, a DNP, and I was told 1999? Was that when it began? No, 2000. 2000. I was going to say 90. Anyway, 2009, you were way ahead of the curve, so congratulations for being on the cutting edge, University of San Francisco. Nursing Workforce Diversity Grant, Section 821, funds projects that increase nursing education opportunities for individuals from disadvantaged backgrounds, including racial, ethnic minorities, underrepresented among unregistered nurses. Through student scholarships or stipend, pre-entry preparation and retention activities, preference is given to projects that benefit rural or underserved populations or help meet the public health nursing needs. Nursing education practice and retention on 831 is really nursing education for our basic undergraduate nurses. We did develop internship and residency programs, which is such a wonderful avenue for help mentoring our new graduates. We were talking out there, and a few of us have war stories, and my war story is my first night as a nurse. Highland Hospital. Night shift. The only RN. One nurse's aide. 21 patients, 19 IVs. You know how it goes. And it's like, well, good luck, lady, bye. So you're there, you know, you got to do it. You do it. But now I think there's a lot more, we're treating our nurses with a little more care and a little more concern. And hopefully hospitals and clinics or wherever you're working, you will partner up with a mentor. And you will have some guidance through that first year out there as a nurse. And you'll get a residency or an internship program to help you through that transition from student to full-blown registered nurse with all those responsibilities. Another program that was really wonderful with this was that we created career ladder bridge programs to help those nurses' aides, LPNs, two-year RNs go on and get higher education, either to get their four-year degrees or go on and get their master's or their doctorate. So there's a lot of career ladder programs within Title VIII. The last, our Section 846, Nurse Education Loan Repayment Nursing Scholarship. I think I've probably said enough about that. But Nurse Faculty Loan Program, Section 846A. Students, you might want to think about this. One of our reasons, and probably one of our biggest reasons for our nursing shortage today, you know how difficult it was to get into nursing school. It's not that that we don't have enough people that want to become nurses. One of the big problems is our lack of nurse faculty out there, enough teachers to help, professors to help the nurses educate. This is a program that funds schools of nursing to establish and operate a loan fund to help registered nurses complete their education in order to qualify as a nurse faculty. Loan recipients may cancel 85% of the loan over 4 years in return for serving full-time as faculty in any accredited school of nursing. So if you're interested in becoming faculty, this is one way to help you educate. But yes, after that, you must then teach in a school of nursing. And last is a comprehensive geriatric education grant to really help train nurses in geriatrics, including curriculum development, faculty training, and continuing education. The baby boomers, we're getting old. You know the statistics. The population is growing older. We're living longer. geriatrics is so critical right now, and it's even going to become more so. So in closing, I would like to thank you all again so much for inviting me here. It truly is an honor, and if there are time, I would love to take questions.
Questions? Anyone?
Just out of curiosity, I'm a graduate of class of 72, and at graduation, there were a number of our classmates, Kathy and I, who worked at the U.S. Public Health Service Hospital out on Lake Street, which of course doesn't exist. Do they have...
1981 is when those closed down.
I was just going to say, do they even have them anymore?
No, there was a big
It's an apartment building now.
downsizing in 1981, and all those hospitals.
Okay. And then secondly, I mean,
But
I know...
yes, we were, a lot of us were in those hospitals back then.
Back then?
Yes, absolutely.
Okay. Yeah. I know that there is nationally a shortage of nurses, but here in the Bay Area, there is an overage of nurses, and it is nearly impossible for new grads to get nursing positions here in the Bay Area.
Okay.
Is this an avenue where new grads could enter? Is it the kind of thing that you want somebody with a little bit of experience under their belt before they enter the service, or is it something that you take new grads and train?
Great question. Yes, we do take new grads. Again, the qualifications are the bachelor's, and congratulations, they all have bachelor's here. We're hoping all nurses have a bachelor's, correct? The difference with us in like the Army or the Navy is you join the Army or the Navy, and they have a force management where they then kind of direct you in where you will go. You're working for the Army and the Navy, and they're going to say, okay, your first assignment is at this fort, and then you're going to do this, and then you're maybe going to go Afghanistan, and then you're going to, you know, they manage your career a little bit more. I mean, you have a lot of say, but they're right there managing your career. We work for agencies, those agencies that I listed. So what happens is a student would, and I didn't bring my website, but you guys are so web savvy, do USPHS, United States Public Health Service, Commission Corps, and our website will pop up. You apply to the Corps, you fill out the application, you go through a medical and a security clearance, you are eligible to become a Commission Corps officer. Then you need to find your own first position. We do have some recruiters that help that, but we don't have a lot of personnel doing it. So then one has to look at CDC, NIH, FDA, HRSA, and find that first job. Me as chief nurse can help you, but I cannot place you in that first job. You have to apply like any other government person or any outside person wanting to join the federal government. You have to apply for that position. You have to go through the interview process and get selected. Once you have that job, they match up your Commission Corps application that you're ready to board into the Corps. You've got a first job, we cut your orders, and you're in. The places that first new grads would have the most area easily of finding a position is in Bureau of Prisons or the Department of Immigration Health Services. They're desperate for nurses, and that would be the perfect entry-level position. Indian Health Service is not as keen about, they would like you to have a few years experience before you go out and work on a Native American Indian reservation. So my suggestion would be especially looking at BOP and Immigration Health Services and working there for a few years. And then, again, then when you want to move and you felt like my first position was in Minnesota, Cloquet, Minnesota. I worked as a nurse, a clinical nurse specialist in maternal child health. I stayed there for about 4 years. After 4 years, I sort of went along, and you all remember Surgeon General Koop. His philosophy was after 4 or 5 years, you kind of get stale. You need to move along. So I felt that. I felt like, I think I started this program, I did good, but I was ready to move on. Then I had to initiate and find that next job. I had to apply down to Atlanta at the regional office in HRSA, and then again at CDC, and then I had to apply again when I moved up to Washington, D.C. So you're really managing your career. You really have to be a little bit more self-sufficient, but yet you have some flexibility. You do get to manage your life a little bit better. There are times, I'm not going to say it's never, that somebody might call you up and say, hey, we really need you to go do this. You have expertise here. Would you please go move and do this? But the movers will come in, they'll pack you up, and they'll move you, and there you go. You know, that's a good question. I believe there's a 4-year commitment when you first sign up. Yes. Yes. Oh, yeah. Yes. Why? Yes. And you know, we have, I'm sure you see a lot of second career nurses coming into the field at 40 years old, 44 years old. The reason that is in place is because you get nothing until you do 20 years. If you get out at 18, you're walking away with nothing. The minute you hit 20, you're vested and you get a retirement. Just like if you're in the Army and you get a retirement. So the government wants to make sure at 44, at 64, and you're eligible for retirement, that's the reasoning for that. Is I think it was related to Social Security at some point, but after your 20-year career, you'd be 64. If you do 30, you're 74, and they think that's... So there's, you know, if you were to join at 50 and you did 20, you're 70, and I guess they're just not willing to... Yes. 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 Well, and you know, the civil service, yeah, there are, you know, I mentioned there's 1,500 nurses in the Corps. There's another at least 3,000 nurses that are civil service federal employees. They don't have that age restriction. You could join the federal government and work as a nurse, and you're just not in uniform. And that's another option. They don't have age requirements for civil service nurses. So you truly could do that, or you could work for like one of HRSA's community health centers, or, you know, a native tribe, you know, an Indian tribe, Indian Health Service. They're looking for nurses all the time. You don't have to be in the Corps or a federal civil service nurse to go work in one of those areas. That's just where we do work, though. Yes, the mercy and the comfort. Well, the mercy and the comfort and the promise, whatever that was called, the promise something, those are Navy ships. They're not our ships. About 4 years ago, maybe 5 years ago, we talked to the Navy and said, you know, we're public health experts. We've got veterinarians. We have physicians. We have nurses. We have pharmacists. We can help you on your missions. And so there was a cooperation between the Navy and the United States Public Health Service. And we sent about 30 people for about a month each year for 3 months on those missions. Now, again, when you're in the Corps, every 5th month you're on a deployment roster. So I would be on the month of April coming up. So I would tell my supervisor, April is my month. You know, if something happens, if the president declares a national emergency, I'm out the door. All of a sudden, about right now, they're starting to gear up to say, you know, the Mercy's going here. We would like to put another 30 officers, interdisciplinary, they're not all nurses, onto the ship. The Navy loved us. They said, great, you have this wonderful expertise that we don't have. Come, join us. So that was voluntary. So if all of a sudden the ship was going out in July and you talked to your supervisor and said, gee, there's this wonderful opportunity, can I apply? And then you apply, and then they they get their mix of their team that they want to send down there for a month. If you make that list and get that team, then yes, it's Commissioned Corps officers. Your supervisor said, yeah, go ahead, go away for a month. You know, I can live without you. Thank you, because they're paying your salary, and you go off for a month and do that part of the Commissioned Corps. Those are not civil service nurses that go do that. You are in the Corps. So there is an age requirement because you're in the Corps. But I mean, I'm not embarrassed to say I'm 57. I mean, I've been in since 86, so what was I? I don't know, 30-something is what I joined. So am I answering your question? So those missions, but you know, they're looking at, I know your local and your state, you should go talk to the Red Cross. There's a lot of other areas where you can sign up and be on a civilian deployment team, especially in a national emergency. Remember back in Katrina, there was all these people that wanted to help, and they've done a lot of progress in helping build a little bit more of a civilian medical corps that are ready to respond in case of another national emergency where we need to deploy people readily. One thing that's nice about the Corps is we maintain a license in one state. So my license is actually in the state of Maryland. It doesn't have to be. If I now move to Nevada, I still have my license in Maryland. So we're federal employees, so our license can be in one state, and we have federal regulations. We don't have to get another license in that state. So we can go down to Louisiana Katrina without having to worry about all the licensure issues. We don't get overtime. So if we're doing a 15-hour shift down in Katrina, they're not paying us overtime. We're civil service nurses, you know, they have to be paid overtime or weekend time and all that. So in that sense, we're easier to move around and deploy to. Thanks. But I would call your Red Cross or your local city, county teams that they have teams to get ready for deployment and response. Yes. Wonderful. Wonderful. Great. Great. Wonderful. Yeah, there's many other, yes. Yes. Nursing, aren't we wonderful? We have so many opportunities in so many different areas. It's a great profession, the best. Thank you. Very helpful.
Well, I think it's time to probably say thank you so much for Admiral Nesseler.
Well, I have a few coins.
She has some presents.
Sister Geraldine, I would love for you to come up and thank you. So I'd love to give you one of my coins, ma'am. This is a public health service nursing coin. So thank you so much. Thank you. Thank you. Thank you. I need to talk to you for a minute. And should I tell her what you could do with these coins? Maybe I shouldn't tell her. But, you know, it's really a challenge coin. If you're at a bar.
Oh, good. Tell me.
It's a challenge, though. I can slap this coin down, and I can say, you know, if you don't have your coin, you've got to buy me a drink. But you know what? If you've got your coin, I've got to buy your drink and everybody else's. So you always try to keep one in your pocket. So there you go. You're safe now.
Thank you. I'll let you know the first call.
Okay.
Stand so I can get both of them.
Thank you. Thank you. Thank you. Wait, I have 3 more.
3 more.
Is Dean Cashmere here? Did she have to leave?
Yeah,
Dean Cashmere?
Dean Karshmer, would you please come to the front? Come on down.
Do you have mine or the nursing one? I have 2 different ones. Show me which one you have. I'll give you the other. I bet you have mine and not the nursing. You have this one, don't you? I bet you don't have this one. I don't have this one. You don't have that
Fab.
one.
Oh, I love the drink part of it.
Dr. James, thank you for coordinating this
Thank
so
you.
much. I
Thank
appreciate
you.
it. Thank you so much. And Mary Lou? Mary Lou. Yes. Perfect. Thank you. Is Mary Lou there? Is Mary Lou.
Mary Lou.
Here you go, Mary Lou. Thank you for driving me around.
I know we're going to hit you. Thank you so
The
much.
only one we didn't get to is Haight-Ashbury.
Mary Lou, come back here.